Okay, I am provided with the MLO view of bilateral breast, and I can appreciate that there is asymmetry between the both breasts. And while focusing and zooming the picture, I want to comment on the parenchyma. The parenchyma is mixed, fibroglandular, type C breast parenchyma, and there is relative asymmetry between the both breasts. The left breast appears to be slightly larger as compared to right breast. No significant uh, mass lesion is noted. There is no skin thickening. No any enlarged axillary lymph node is noted.
And what would you normally like to see in your usual practice mammogram? So you've seen the MLO views.
Pardon, ma'am?
What would you like to see as well as your MLO views?
Ma'am, any mass, any asymmetry, architectural distortion, axillary lymph nodes.
Okay, I've got the CC views for you now as well.
Yes, I want to see the CC views as well. Outer quadrant of the left breast, there is a very well-defined, rounded, radio-opaque lesion, which has regular and smooth margins. It is very well circumscribed, and it has no any area of internal lucency or any abnormal calcifications. There is no breast architectural distortion.
Yeah.
And it appears to me very well defined and benign lesion, likely Barrett's 2. And I would like to do ultrasound to know the cystic or solid composition of this lesion. And I'm provided with the transverse ultrasound of the breast. And this is, yes, ma'am, of the same region. And this is a very well defined and a quick lesion with the significant posterior acoustic enhancement and rounded and small. It is not causing any, there is no any posterior acoustic shredding and abnormal calcification within this. So likely this is a benign lesion, likely a breast cyst, Barrett's 2.
And what would be your normal management?
And ma'am, this is a benign lesion, so no follow-up will be suggested to this patient. Annual routine screening will be suggested according to the patient demographics.
Yeah, that's wonderful. So that's exactly what we would do. Your presentation of the mammogram and ultrasound were very good, very clear, and your management plan was good. Often in the UK, we offer them aspiration for symptomatic relief.
Okay, aspiration.
That's, patient choice. We don't. If patient wants it aspirating, we'll aspirate it for them, but there's no requirement to do that. So,
okay,
yeah, that's wonderful.
Thank you.
These are the medial lateral oblique views of the right and the left breast. The breast parenchyma are predominantly fatty, and first I'm looking at the chest wall. The soft tissue of the chest wall appears normal, and I do not see any enlarged lymph node in this region. Secondly, in the left breast, in the MLO view, I can see that there is a well-defined, however, ill circumscribed, poorly circumscribed, dense lesion in the lower quadrant of the left breast. And I can see that there are speculations, and probably there is a bit of a tiny focus of calcification. However, I will try to confirm it on a magnification view. Apart from this, I cannot see any other lesion in the right or the left breast. I can see that the soft tissue, the skin thickness is normal, and there is no skin or nipple retraction. So on the yes, I think there is a probably there's a bit of a tiny focus of calcification at the site of that lesion. So I would complete this study by looking at the CC view also. I would request for the CC views of the left breast. Okay. in the CC view of the left breast, I can see that the same lesion which I described on the MLO view is centered in the center of the left breast, and it is well defined. However, poorly circumscribed. I cannot really draw around it, so it has got some speculated margins. So based on these findings, I can say that this is probably a malignant lesion, likely Biret 4 lesion. And next, I would like to do an ultrasound of this region and also confirm it on histopathology. Okay, grayscale ultrasound is provided to me. There is a well-defined and hypoechoic lesion which appears to be. Ma'am, if you please remove that marker, I can.
Sorry.
Okay, that's enough, I think.
Yep. So,
Yes.
so your score is IRADS 5 for the mammogram and for the ultrasound.
Yes, it's definitely looking like a malignant lesion, and it's digging deep into the breast parenchyma rather than horizontally orientation. However, then there are speculations, and it's likely it's kind of multilobulated type of lesion. However, on Doppler, I do not appreciate any internal vascularity. Still, it is highly malignant looking lesion between.
What would you normally do in your normal practice?
Hello?
Hello, can you hear me?
Hello? Yes, yes.
What would be your normal management now?
In this case, we are definitely going to biopsy this lesion.
Yeah, and what else would you want to look at as well in this patient?
On mammogram, I didn't see any axillary lymph node. However, the ultrasound, on ultrasound, I would like to go for the axilla for evidence of any malignant lymph nodes. And the rest of the breast should also be, completely scanned with ultrasound. If there is some lesion which we have, didn't pick on the mammogram, we can pick on ultrasound.
Yeah. So in the UK, our normal practice, we don't tend to scan the whole breast. If we scan the area of concern, unless the breast, always make sure you mention about referral to the multidisciplinary team. I was due to say this is an ill-defined, I'd say spiculate lesion within the central left breast. It's about 6 o'clock if you look at the mammogram. I would say density. I would use the word density. You could say ill-defined density or spiculate mass. That would be quite reasonable. I'd be quite happy with that if someone described that to me. It's just to note there is some calcification in this breast tissue, but it's benign. It looks as though it's dermal calcification, so that can be ignored. You wouldn't get penalised in the exam for not mentioning that. But well done.
Thank you.
These are the bilateral silicone implants of the patient, in which I can see that the silicone implants are not regular along their upper and lower region in the MLO view, which is provided to me, and soft tissue haziness is also evident along the upper part of the bilateral pectoralis major muscles. The surrounding and the skin appears normal to me, that it is not inflamed. However, some fatty strandings are evident in form of haziness. In my provisional diagnosis, it is a rupture of the silicone implants, likely extracapsular. I will refer this patient for MRI to see whether there is evident intracapsular rupture or not, through the signs which are available on MRI, like the linguinal sign and goblet sign.
Is there anything you would do in clinic at all to, because you had the patient with you, would there be anything else you might do in clinic? What else would you have available?
Ma'am, I will do ultrasound of this patient.
But they did demonstrate something else. So what do you think this is?
On ultrasound, grayscale image, I can see that ill-defined opacity with some internal echoes, homogeneous in texture, evident with which is wider in width.
Yeah. And what do you think that is?
That is some underlying mass.
Is it a mass or could it be something else? So you've already mentioned that the implant's ruptured.
Yes, then implant structure, it is snowstorm pattern in my view.
Yeah.
That is evident on the ultrasound in case of rupture, ma'am.
No, excellent. So it shows that there has been an extracapsular rupture of the implant. The implant is irregular, and there is silicone in the axilla. This lady was a little bit more complicated. She had had implants before which had ruptured. So we were unsure whether this silicone was due to the current rupture or whether it was from the previous rupture. So like you recommended, she went and had an MRI of the breast. If you could describe that for me, please.
It is quite irregular in shape, extending up to the axillary region, and more irregularity evident along its inferior margins. Some keyhole. Yes, now in this section, I can see hypointense strips along the in the silicone implant.
Yeah.
Now the capsular irregularity of the silicone implants more evident in this view on the left side. As you have scrolled on previous image, I can see that some hypointense bands, these are seen along the margins of the silicone implants, regarding giving the keyhole sign that they are indented inwards towards the implant.
Yeah. So
yes, now this is the yes, ma'am. Now on the right side, it is the keyhole sign along with yes, ma'am, the inferior one.
Do you think this is a current rupture or an old rupture? So I think you've already described it already.
Yes, ma'am. It is a silicone implant rupture, extracapsular and intracapsular also.
Brilliant. Yes. So we only do very short sequences for our silicone. We do silicone sensitive sequences. We don't do a full MRI. I don't know what your protocol is, but it demonstrates the silicone in the axilla like we saw on the ultrasound, and it also shows the extracapsular silicone, and it shows the little sort of air bubbles within the the little areas within the implant. And you've got the sort of the linguini sign as well.
Yes, ma'am. Linguini sign. This one is cool. Keyhole sign. Okay.
You did very well. Not an easy.
Thank you, ma'am.
Thank you ever so much. So this is another Nick. She's a null having previous surgery, and she came to clinic with breast pain this time. So okay. I'll just mag up the mammograms because they are quite small.
Okay, these are MLO views of bilateral breast. In the breast parenchyma is mixed, composing of both fat and the glandular component. I can appreciate metallic staples within the left breast parenchyma, consistent with previous history of surgery. In right breast parenchyma, I can appreciate few rounded punctate type of calcifications, predominantly in the upper quadrant, in the outer quadrant. These are, but I cannot appreciate any discrete radio-opaque lesion within both breast parenchymas. Also, there is no evidence of architectural distortion, any skin thickening or nipple retraction. A few rounded radio-opaque lesions are noted within the axillary region. These are consistent with lymph nodes, but they have preserved fatty hilar regions. As I cannot appreciate any clear-cut discrete lesion and I can see only a few specks of calcification, I would likely to go for the ultrasound of the patient or any previous imaging to compare if there is any occurrence of new lesion.
Can I just, what I'm going to do is just mag up the this mammogram on the left for you, if that's okay.
Okay.
Can you see this here a bit better? I don't know how it projects on your computer.
Okay, in magnification view, I can appreciate few micro calcifications which are of different in shape. Few are elongated and few are pinpoint nodular. So, and these are in a clustered orientation. So these are pleomorphic type of calcification, but I cannot appreciate any discrete radio-opaque lesion. So I will do a compression view next.
Okay, so, and I've got this CC view. Can you see that?
Okay, at CC view, I can appreciate an ill-defined radio-opaque lesion in the inner quadrant that has central lucency, and it is associated with multiple specks of calcification at its anterior aspect, and posteriorly its margins are speculated, and these are merging within the adjacent breast parenchyma. So I am thinking of a suspicious lesion with pleomorphic type of calcification. For further confirmation, I will do ultrasound of the patient to better delineate this lesion.
So you were right to suggest the magnification views. Unfortunately, because of this lady's breast pain, we tried and she wasn't able to tolerate it. If I do the ultrasound now, there wasn't anything obvious on there. There was a small seroma from her wide local excision, some skin thickening from the radiotherapy, but no discrete lesion. So what would be your management then?
So ma'am, it can be a post-radiation scar with central lucencies and calcification. But as this scar is also associated with the further chances of malignancy, so I will further elaborate this lesion with MRI breast.
We don't normally with the calcification, we don't normally routinely do MRI for these lesions. Just for calcifications, sometimes you may see some non-mass-like enhancement, but the most important thing here is to sample this calcification.
Okay.
How would we normally do that?
Okay, I will go for biopsy and histopathological correlation if this is a recurrence of mass or if this is just a post-radiation scar.
Yep. Okay. So, and what we normally do is to do a stereo biopsy. So we sort of localize it with the mammogram machine, and we do a stereo vacuum-assisted biopsy. Remove the large volume of the tissue, and then we X-ray the specimen to make sure we've obtained enough calcification, and we put a marker in the area where we've taken the calcification in just to confirm we've got the correct site. So what BioRad score would you give the initial mammogram?
I will do it as BioRad 4C, as this patient has also history of previous cancer and there are suspicious calcification in mammogram.
Yeah, I think that's quite reasonable. We're not sure. It could be related to the patient's previous surgery. But of note, I went back and looked at her previous mammograms, which we've got hard copies of from her previous cancer, and she did actually have a DCIS as well. So this actually on biopsy turned out to be the histology was DCIS on the mammogram, and he ended up having a mistake. I thought this was probably more a 5. If I hadn't had surgery before, I probably would have given it a 5. But because she's had surgery, people who have fat necrosis and scar tissue, they can calcify that tissue in different ways, but generally that tends to be a lot more chunky calcification. So I don't know. I think sometimes imaging wise, I don't think there's much between a 4 and a 5. I think it's probably a bit more branching, a bit more sort of in the ducts. I'd go for a 5. I think if it's a bit more finer and scattered, then I may probably err on the 4.
Okay, so you mean to say that when there is a pleomorphic branched calcification, then it goes towards 5 rather than 4, right? That okay.
Small calcification. It's localized. I probably err on the side of a 4. And if it's doesn't really fit any, we often, if we're not sure and it's not obviously, we very rarely call calcification 4s. It's either obviously malignant or we're not.
Right.
So we tend to only ever really use sort of 3 or 4 if we're doing 3 or 5s if we're doing biopsies.
With the MLO view of right and left breast with the ACR pattern 2 in the given left breast area, I am able to appreciate that there appears to be coarse trabecular pattern of the breast with radiopaque density in the inferior border of the inferior and middle border of the breast, having irregular margins with the overlying skin thickening, and few and large lymph nodes are also seen in the left axilla, and right breast appears to be fairly unremarkable. I would also like to have a look at the CT view, and if there is also any previous imaging available, I would also have a look at this to see. Okay, now this is the CC view of the both breast, and again the findings are fairly similar in this case, with the more central in position lesion having thick overlying skin thickness, and I'm unable to appreciate any calcification in the given lesion. The lesion is not clearly visualized. I would like to have a spot compression view to look for its margins.
Yeah, so we decided against spot compression use, but that's completely valid. It was a busy fast track clinic, and have time to do it, but we weren't sure that it would really add anything, but it's perfectly valid to do that. What would you do next?
So I am on the basis of this, I am suspecting it to be an aggressive lesion, likely BI-RAD 4C, and further I would go for an ultrasound imaging. Okay, I'm provided with the grayscale imaging ultrasound of the same patient, and in this image, I'm able to appreciate that there appears to be an anti-parallel ill-defined hypercoic lesion having posterior caustic shadowing, which appears to be inseparable from underlying muscles, having spiculated margins. I'm unable to appreciate any calcification, so to me it appears to be a suspicious lesion, again category U4, and I would refer the patient for biopsy and multidisciplinary management.
While you're scanning the patient, is there anywhere else you would look?
Yes, of course. I was able to appreciate enlarged lymph nodes in the axilla on the ipsilateral side on it. So obviously I will go for ultrasound scanning of the axilla and the contralateral breast. And this is right. I'm able to appreciate that there appears to be enlarged lymph nodes, though there is slight disruption of the cortex and medulla with increased cortical thickening, and peripheral blood flow is noted, which is again is a sinister sign in this case. So these might represent some disease spread in this region. So these appears to be suspicion nodes. Suspicion of the malignancy is there in these nodes. So this is also
so
confirmed to my findings. So this is likely BI-RAD 4C.
Yep. So we thought both the ultrasound and the mammogram were overtly malignant. The whole breast, even though there's this focal area centrally, the whole breast we thought was abnormal. You've got some diffuse skin thickening within the left breast. It just appears a lot more thickened than you would normally see. So we just thought it was, you know, a huge area of involvement. Yes, you've got this focal area lower down, but the whole breast appears different to when you compare it with the other side. You've got these axillary lymph nodes. Again, it's not easy to appreciate an ultrasound, but there's quite a lot of skin thickening, and the soft tissue just appears diffusely abnormal when we scan through. And there was more than one hypoechoic area. So there was this area in the lower inner quadrant, but when we scanned through, there was several areas throughout the breast. So the whole breast tissue just looked abnormal. So we gave this an M5U5. Right. As regards the axilla, if you look at the nodes, our criteria for biopsying are if the cortical thickness, so this distance here, is more than 2 millimeters. So that's the central fatty hilum. And if you get this distance here, we normally biopsy if it's more than 2 millimeters. I think this is about 5 millimeters. It's huge. Yes. So this is definitely biopsiable, but some centers only do 2.5 millimeters and above. So, but we do 2 millimeters, and we seem to have a decent pickup rate. Sometimes the lymph nodes are just completely replaced by tumor. So my BI-RADS score would be M5U5 for this lesion. So with this patient, it was difficult to really, as you said from the mammogram, difficult to actually get a definite size of the lesion. So we progressed to an MRI of the breast.
Right.
Just to see if we could assess the size of the tumor. Okay. So if you bear with me, I'm going to go to the subtracted images, if that's okay.
Right.
But we'll run through the MRI a bit afterwards. So if we start with the subtracted images now, so I'm just going to scroll through these. Okay.
Right. Could you please, yes. This is the lower quadrant lesion, lower down, which we'll be talking about, with speculated margins and with the coarse trabecular pattern and overlying skin thickening and enlarged axillary lymph node. I think there appears to be another lesion close to the axillary tail, which shows speculated margins. So that might be suggestive of some multicentric carcinoma in this patient.
Yeah, it almost looks confluent. If you look at it, you've got your axilla there, then you've got this lesion here, and it all pretty much appears confluent with the main mass.
Right.
If I show you the MIPT images, so just bear with me. So these are the MIPT images, and you can see you've got the main tumor mass.
Yes.
It just appears confluent with this area in the left breast. Okay, so this would be an MRI on the BI-RADS scale. This would be a 5.
This would be a 5. With
axillary involvement. We also don't forget to look at the opposite breast.
Right.
And there's some enhancement there.
Yeah,
okay.
right.
Obviously, we know this is malignant, but this, we're not sure. We've not seen this in the ultrasound or anything like that. It's just some enhancement on the MRI. I wouldn't routinely do the curves for this one, unless it was for a teaching curve, but I'll show you them in a minute. But for this one, we would do a curve, and this turned out to be a benign lesion on the curves. I've got if I just bring up this image now of the graphs. So I can't actually do the machine doesn't save the graphs, and it takes an absolute age to generate new ones. But if we did the graphs of that patient with the left breast tumor, you would see quick
curve number C,
yes.
Probably.
Yeah, so you'd see a washout curve. So you'd
rapid, rapid washout.
Washout, okay. Occasionally in the sort of smaller ductal cancers, we often see these sort of plateau curves. which are sort of indeterminate for malignancy. Okay, so you'd see it rapid uptake, but you'd just plateau of the contrast uptake. And the benign lesion on that scan just showed gradual uptake. It's gradual increase in uptake, and that was a benign lesion which was confirmed on ultrasound. It was just a small fibroadenoma on ultrasound. Okay, normal tissue just shows a gradual increase in uptake. So, like I said, we wouldn't routinely do curves for something that we know is malignant, and obviously malignant is in that case, but for teaching, this would show rapid uptake.